This conference will now be recorded.
Okay, so far we have seen tumors of the external layer, which was basal cell carcinoma, squamous cell carcinoma, and some other conditions. Then we have seen the benign tumors of the exnotic canal. That they were exostosis, osteoma, keratoacanthoma, pyromatrixoma, and on. Now we have seeing the benign tumors of the middle ear cleft. They are adenoma, osteoma, pleomorphic adenoma, choriosteoma, meningioma. So all these histological diagnosis. So here you can see the in the picture osteum of the mastoid. So this is the post-auricular region, and you can see a smooth elevation here. When you palpate, it will be very hard. It will be bony. So you cannot do a biopsy also here. So when you do a CT scan, you will be knowing that at the mastoid hair cells there is some bony projection that is known as osteoma. So what are the malignant tumors of the temporal bone? Squamous cell carcinoma, adenoid carcinoma, rhabdomyosarcoma. So these are the most common actually. Others are not that commonly seen, but these are all the types of malignant tumors that can be seen. They have in the literature we have all these conditions. So melanoma can occur, osteosarcoma, CNS malignancy, lymphoma. So all these can occur. So what is the pathogenesis of the malignant tumors? Generally the chronic otitis media, that is the most common pathogenesis. Due to the prolonged infection, it can turn into a pre-malignant condition, and then the cancers can occur. Actinic rays, trauma, frostbite, psoriasis, xeroderma pigmentosa, chronic otitis externa, radiotherapy. So all these are some of the causative factors for the malignant tumors of temporal bone. Generally seen in the old age. Exnotic canal, squamous cell carcinoma is the most common. Hidradenocarcinoma is also seen. BCC, melanoma, mucoepidermoid carcinoma. These are generally seen in the exnotic canal. Whereas in the middle ear, we see the squamous cell carcinoma is the most common one type. Adenocarcinoma followed by and basal cell carcinoma. So these are some of the tumors that cancers that are seen in the malignant tumors that are seen in the temporal bone. So how do they extend or how do they invade the other tissues? So whether the squamous cell carcinoma, whether it is a squamous cell carcinoma of the external auditory meatus or in the medial ear, what happens is at presentation both the areas will have a perforated tympanic membrane. So due to the perforation of the tympanic membrane, there is a chronic suppurative otitis media, and due to the continuous infection of the middle ear, the exnotic canal cells can also get turned into a pre-malignant condition. So when there is a perforated tympanic membrane, the growth will accelerate, and it will occur at the junction of the cartilaginous and the bony part. Generally, at this cartilaginous and the bony part junction, it will start. It can invade the thin wall of tegmen. It can go into the tegmen area. It can go into the mastoid antrum. It can go into the hypotympanic, that is towards the jugular bulb, medially towards the petrous apex, peritubal cells, that is surrounding the eustachian tube. Infratemporal fossa can also be invaded, and certain parts are resistant to spread also, and cervical lymphadenopathy is also seen. So if a tumor is present, you can see this is the tumor which is extending inferiorly. This is the tubal area. This is towards the tegmen. So tegmen area, this is towards the mastoid area. So you can see it is extending towards everyone. This is the mastoid bone. So whenever it starts at the bony and the cartilaginous junction, and it can go into any area. Okay, it can go into all the surrounding areas. That's why it is very difficult to treat the malignancies in the middle ear. So this is how it will. The patient will come to you with some bloody discharge from the ear, and when you just try to see, you will be seeing a mass coming from the exnotic canal. And when you try to probe it, the patient it will be painful and it will bleed. So when you go for a punch biopsy or you can, for a small excisional biopsy, after doing a histopathological examination, you will come to a diagnosis of squamous cell carcinoma. Then you will follow it up with a CT scan, and that will give you the extensions of the CT extensions, and that will determine the treatment part. So growth, there will be some growth in the ear, there will be pain, there will be discharge, and the patient is not able to hear as the sound vibrations cannot reach the middle ear. So there will be deteriorating hearing also, and that can all, and that tumor can also invade the ossicles, so that will decrease the hearing. Facial paralysis can occur because due to the breach in the facial cortex, facial nerve, if it invades, then facial nerve paralysis will be seen. Lower cranial palsy, if it reaches the jugular bulb area, then the lower cranial nerves, that is 9, 10, 11, and 12. So these will also be involved, and lymphadenopathy is sometimes seen. What are the differential diagnosis? If the patient comes to you, you can have one of your diagnosis, differential diagnosis as squamous cell carcinoma, but generally the most common one is otitis externa or the chronic otitis media. It can be granulation also. So when the patient comes to you, you should think of these two conditions first: otitis externa, whether it is a malignant otitis externa or a chronic otitis media. At a later time, at a later time, it will when you do a biopsy, then you can come to the diagnosis of squamous cell carcinoma. So it's a multimodality imaging you have to do. You have to do a CT and also an MRI. Excuse me. Um, okay, so it's a multimodality imaging. You have to do a CT and also MRI, as most of the soft tissues involved. So you have, and facial nerves and other cranial nerves are involved. So MRI is also required, and CT to know for the bony invasion. So in the coronal cuts, you can view the exnotic canal, otoretic wall, tegment tympani. So all these can be appreciated in the coronal sections of the CT and MRI. In axial sections, you can also see the posterior and the medial invasion of the petrous pyramid, carotid canal, lymph node detection, prevertebral spread. So all these can be seen in the axial sections. So this is axial section. So where you can see the posterior and the medial, all these can be found out. Then you have to definitely do a HPE. Multiple biopsies have to be taken to come to a diagnosis. FNAC is generally done CT guided. Angiography is also sometimes required, whether the carotid or the jugular IJV is involved. So angiography is also done for the major vessel invasion present or not. Audiometry is done for every patient to see whether there is any hearing present or not. Then there is a staging for every cancer. The staging has to be done. DNM staging has to be done. So T1 is EAC without bony erosion or evidence of soft tissue. Means it is only present in the EAC, but there is no bony erosion. Limited EAC bony erosion is present, and it is less than 0.5 centimeter, then it is T2. More than 0.5, then it is T3, and it also involves the middle ear and the mastoid or both. If it has involved cochlea, petrous apex, or the everything every other parts, then it is T4. Okay, so T1 is only present in EAC, T2 less than 0.5 centimeters and some bony erosion, T3 more than 0.5, that is full thickness of the bony EAC is involved, and if it is invading to all other structures, then you can consider as T4. So these are the end staging and the M staging. This is the this is how it is staged. Then the surgical treatment, it's followed by radiotherapy, and surgical treatment is followed by the radiotherapy. Extent of surgery is controversial. Generally, it is removed as a end block. Radical mastectomy is done, and problems of local recurrence is always there. Extensive surgery is not required, is done for the bigger. When it's a T4, you have to do an extensive surgery. Complete temporal bone dissection has to be done. So when it is only present in the T1, then only this part of the red line part will only be removed. Okay. When T2 is there, then the blue line means you can use the complete osseous canal along with some part of the mastoid is also removed. Okay. Entire external canal with TM, with malleus and with incus, everything is removed. Superficial parotomy is also done. Incision tube is plugged and facial node dissection is also done. When it is a very large, it is T3, then you will remove the whole green color, means them you remove this whole temporal bone and you will totally close it. That is in the T3 and T4. So what is modified lateral temporal bone resection? It is the tumor extension to tympanic cavity or the mastoid cells. So facial nerve is sacrificed, posterior petrosectomy is done, tegmen, perilabyrinth and retrofacial cells down to jugular bone all are removed. Okay. And what is subtotal? It is done in T3 cases. It is entire temporal bone lateral to petrous carotid artery is removed if necessary. Portion of dura, sigmoid, parotid, ramus of mandible, parotidectomy is also done. Facial nerve is transected. If it's a total T4, then you have to go for a total temporal. That is, you have to sacrifice the carotid artery. The most important decision is not to operate at all. Generally, if it is T4, it is better not to operate, because if you remove this whole of the structures, then the patient will have a lot of problem, because one, you have to sacrifice the carotid. If one of the carotid is removed, then the patient cannot live. It will be a problem for him. So generally, it's not done. Invasion of the cavernous sinus, ICA, infratemporal pulse. So all these are generally removed if in a case of total temporal bone resection. Radiation therapy is preferred rather than surgical in extensive cases. So 5-year cure rate is around 28.7%. That is very good. And so RT plus surgery will give us a better, that is 59.6% survival rate. Radiation alone can also be done, and complications will be there for surgery or for the radiation. And treatment of metastasis has to be done, but if your neck dissection is not done, there is no improvement in survival. So what are the other epithelial malignancy? BCC can be seen, or melanoma, adenoid cystic carcinoma, ceruminous. So these are all the other some types of malignant cancer seen in middle ear. Radiation and malignancy is also seen. Tumors in childhood. Rhabdomyosarcoma is generally seen in the childhood area, not in the old age. It's an extremely aggressive and perimeningeal common tumor of childhood. Ear is the third most common after nasopharynx and orbit. So in a child, if it's rhabdomyosarcoma occurs first in the nasopharynx, then in the orbit, and third one is the ear. Okay. So these are some of the types of rhabdomyosarcomas. These are the this is the how the child will present to you. The patient will come to you with mass in the ear region, oral polyp, ear discharge, bleeding from the ear pain, hearing loss, facial paralysis. So this is how the patient will come to you. Rhabdomyosarcoma in the pediatric. Diagnosis by biopsy, fluorescence in situ hybridization, PCR is done, then bone marrow test is done, CT and MRI. So group 1, tumor completely removed. Group 2 is microscopic residual tumor, involved regional nodes or both. Then group 3 can be residual tumor. So this is how you classify when the after rhabdomyosarcomas. Treatment is multimodality. So you have to at least take out 2 centimeter margin. Chemotherapy can be advised. Vincristine, dactynomycin, ifosfamide are generally given. IMRT is also followed in some centers. So this was the external ear and the middle ear cancers or the tumors, benign tumors. I don't think so. I'll share this PPT. Please don't go don't read much about this class, because this is generally not asked. Generally not asked. Don't worry. This was just for to complete your syllabus. Have taken this class. I'm closing it. Thank you so much.